We can
Okay, so all right. Ladies and gentlemen, Assalamu alaikum, good evening, and a very good morning to Dr. Rizwan Naeem in New York, where I believe it is 8 in the morning. So on behalf of the Pakistan Society for Immunology, I would like to extend to you a very warm welcome to today's webinar. This is the first session of a 3 series of webinars on diagnostics, management, and clinical research on COVID-19 pandemic. I offer my profound thanks to all the speakers for accepting our invitation to participate in this activity. A special thanks to our international speakers, Dr. Naeem, Dr. Sophia, and Dr. Muhammad Abu Zaid for accepting our invitations. And unfortunately, Dr. Stephen Reynolds, who was going to be talk about the indeterminate PCR results today, has taken ill and will not be joining us today. So we are going to miss an important aspect of PCR testing being faced by laboratories everywhere. And I do hope that Dr. Naeem will cover this aspect in his discussion. We all know that these are unprecedented, difficult times being faced by people across the world, and COVID-19 recognizes no boundaries. And this underscores how we are all connected in this world. It is only by working together and sharing our experiences that we will be able to overcome the challenges we face during this pandemic and beyond. And I would also like to thank the Association of Molecular Pathology Pakistan for joining PSI in holding this webinar. And to begin the program, I now turn over the webinar to Dr. Sabia.
Thank you, Dr. Rana. Now I'll pass on this mic to Dr. Natasha, who's now going to coordinate with Dr. Rizwan for the next for our first presentation. Dr. Natasha, over to you.
Thank you, Dr. Sabiha. Thank you, Dr. Rana. A very warm welcome to all our audience today. It is really a privilege and an honor for me to be moderating this session for a number of reasons, which I'll go into once we have our discussion. But really, it is a pleasure for me today to present to you our first speaker, Dr. Rizwan Naeem, who is the Director of Molecular Pathology and Fellowship Programs at the Montefiore Medical Center, Albert Einstein Medical College in New York. Dr. Rizwan Naeem has had over 3 decades of expertise and experience in molecular pathology and molecular genetics. Very quickly, just to give you a bit of a background to his experience, he completed his fellowship in clinical cytogenetics from the University of Boston in 1991, and then went on to do another fellowship in molecular genetics from the Harvard Medical School in 1993. Since then, he served a number of positions and posts, and essentially has been key in sort of developing molecular pathology services in a number of institutions. He's worked as a consultant at the World Health Organization Genetics Division and as a reviewer for a number of articles and grants. His commitment to sharing his expertise and experience is really profound, and more so for us in Pakistan, because you know, he's been engaging with us over the last many years, and he is also a founding member of the Association of Molecular Pathology Pakistan, and is involved in a number of philanthropic activities here as well. So without further ado, enough from me, and now I'd like to invite him to kick off the webinar series with a very important overview and an update on the current status of laboratory diagnostics for COVID-19. Over to you, Professor Naeem.
Thank you very much, Natasha, and it's been a pleasure to be here and be part of this much needed conference. And I think one of the things which I'm really proud of is the speed and status of molecular diagnostic as reaching in Pakistan at a very, very high level and speed. So without further delay, what I would like to do is share my screen, and let's see if I can do that. And you see my screen? Yes, okay. So you know, today's talk it's not very long, but I would try to explain that, just bring you back from historical point of view where we were and where we are, and what is the status in US, for example, and key things which we need to remember, and of course, I will be covering test interpretation as what to do if there's an indeterminate test is, or what are the reasons for those for those results. So without, briefly, there, like, coronavirus is not something new for humans. It's been there around for a number of years. And so there's many different type of flu viruses which are of corona family. But the two beta coronaviruses, they cause more severe disease and outbreaks. SARS-CoV-1 responsible for SARS break in 2002 and 3, were about 896 cases uh, uh, with uh, with 774 death. And MERS was also a coronavirus, which was we saw it in 2012 outbreak. But SARS-CoV-2, which is we are dealing with now, is under the beta coronavirus genus and is the seventh coronavirus identified to infect humans. So this is a notorious virus. And it was first identified in Wuhan, China, as we know, and in January, end of December 2019. That's why some people call it COVID-19. But it was December 29th or 30th when Chinese government has published it and advertised, made it aware to the world. So World Health Organization took almost 5-6 weeks to formally characterize the global spread of coronavirus as pandemic. The International Committee on Taxonomy and Viruses renamed 2019 nCoV as severe acute respiratory coronavirus, or SARS-CoV-2. So this was the update when I was making slides, July 6, 6:50 a.m. And remember this is like, it's changing every day. So today's number will be definitely different than what these numbers are. The total confirmed cases globally now at present is about 11,465,000, and total deaths are about 530, close to 550,000 deaths now. And there are a good number of recovered patients also. So what in US, and we know that it's a grim July for us. We thought that warm weather will cure this and virus will not spread as it is spreading. It was spreading in January and February and March, but we see very different story. We see that 250 new coronavirus cases in just 5 days of January, like January 1st, sorry, 5 days in July. And as you see that US, Brazil, US are the two most rapidly still growing number of cases. But one interesting thing we see is this recently, it was from yesterday, that India has become the third highest COVID infected country now. Data by the health ministry shows that about 23,000 new cases and in previous 24 hours, bringing country total of 700,000 and about above 20,000 death. And we all know that both India and Pakistan, the death reporting is not very accurate. So the death rate may be more than what we see in literature and government is telling us. So now come back to why is testing important? Why COVID testing is important? As certain countries like Sweden or our president also sometimes they don't do testing and don't do testing. And if you don't test, you don't do testing, you will not have cases. But it's a very different what we call a scenario for people who work with healthcare. And I will give you an example why the testing is important and what different type of testing we should be doing, and what are the quality control measures of these testing. So virus is both highly contagious and relatively lethal, with mortality rate that's still uncertain. It depends on different population group, different age group, and so on, but higher than that of flu, almost 10 times or more higher than the flu we have seen. So it is a high mortality rate. It can be spread by people who, the most important part of this virus really is this, that it can be spread by people who don't even know they are infected. And in contrast, victim of the original SARS, which is the same family virus in 2003 and 2012, contagious until very severe symptom strikes and making it easy to isolate these people and cut the chain of transmission. So cutting the chain of transmission is not it's difficult in this virus because there are a lot of silent carrier who are just spreading it. They may not be affected, but who they affect will be affected severely. The people can have COVID-19 without symptom is one of the most challenging aspects of preventing spread. So most people never show classic symptom. This was a study recently published. It's a research study that 5,448 people who had close contact with infected person. Roughly half got infected, but only 31% developed classic symptoms, such as cough as a person's age increased. So did their odds of experiencing symptoms. So older patients are much more affected than younger patients. But this is an interesting fact which we have to realize. So what I believe, and many in US believe, there are three groups of people who should be tested and tested regularly. People with any COVID symptom to spot new cases as soon as possible. By identifying the new symptom as soon as possible helps you isolate that person and stop the spread of viruses. The second important thing is people who have been in contact with the infected person also should be tested, even if they have no symptoms. So that's I was saying that even if they don't have symptoms, 6 of the 8 of the 10 people who are in close contact with the infected person can be a silent carrier. The third group of people we recommend very heavily to be tested are the healthcare providers for antibody testing the virus to identify those who may have already been infected. So that's a good thing to know that if you are infected and maybe your immunity, you have developed immunity and maybe your symptom will not be as severe as the first time around, or the second part is this also that, but that there's something to remember in the third point, that if you are infected, a lot of people say that, oh, by the way, I'm infected, I have no problems anymore. That may not be true, because infection your body can take the virus. It may take it may be much better prepared to fight with this virus and eliminate this virus and not give you symptoms, but that doesn't mean that for the short period of time you will be transmitting virus for people who do not have. So, that's why the testing is important, but we have to keep that in mind. So how do scientists test for this new coronavirus? Of course, we have to identify the sequence for this virus. This has been sequenced at multiple times in different areas of country. It is mutating very well. So we need to find virus reproduces by getting into human cells, then hijacking the cells machinery to make many copies of its genetic material called RNA. This is an RNA virus. Scientists have designed several testing methods to spot this distinctive viral RNA. The genetic material is typically purified and then copied from RNA into complementary DNA, and the DNA is then copied millions of times using a standard method known as polymerase chain reaction, or we call it, in this case, it's a real-time polymerase chain reaction. Finally, a fluorescent probe is added that emits a glow when DNA copies of the virus are present. So higher the number of copies of virus are, the higher the glow will be. And then you have to put up, I will show you, you have to have what we call a CT value, which determines if it's positive or not positive, or different scientific terms. But important thing is that after sequencing, we identified areas of the genome of virus RNA which is conserved, which is not mutating or mutating at a slower rate than the highly virulent form of areas where the mutation is very common. So now the question is, why and how do we get tested? So we all know about molecular assay or molecular testing, or RT-PCR, real-time PCR testing. This is done to detect genetic material, RNA of the virus in a sample. So what sample types? Nasopharyngeal swab, nasal swab, or throat swab in some cases. Recently in US, many labs and places have validated saliva sample for the testing also. So it depends what you are using or what test you are using, or is it a homegrown test? So have you validated on different type of samples? The samples are, these are the different sample types where this RT-PCR can be done, and you can detect number of copies of this virus. The second important test is called serological test, which is antibody-based test. Detect antibodies of SARS-CoV-2 that indicate you have been exposed to the virus, mostly to help track the pandemic. And for that type of testing, blood samples or finger sticks are taken. And the third type of testing is called antigen testing. Detects SARS-CoV-2 protein has been developed but are not yet widely available for many, many reasons. And one of the reasons is you have to be very sensitive or for this testing, or and it is available by companies, but not many people are using. I'm not sure the status in Pakistan, but US we are not satisfied with the detection rate, false negative rate, false positive. So another important thing which we have to realize is WHO really has published this back in March, where they have sequenced this whole genome for this virus, and they have provided different type of primers, published different type of primers, and these primers are publicly available. So any lab who has a real-time PCR setup and has some experience can basically develop their own assay. You can use one gene, you can use two genes, or you can use three primer sets of three genes. So higher the number of genes you use, probably more sensitive your assay is, and you will avoid new mutations not being detected, or and so on and so on. So initially when it happens, we developed our own assay, and it was working perfectly. You can do it with one target, two target, or three targets as you wish. And I'm sure that Aga Khan University has also done the same type of thing. And then now we have moved on to kit-based testing, which is emergency use only for COVID viruses, and it's a high throughput assay by using a kit-based assay. But these virus sequences are available, and people have developed their primer sets based on this finding, and that's why WHO has a very big jump and good jump this viruses. But unfortunately, places like US and Pakistan both have a hard time catching this control of this virus. So what is a SARS-CoV-2 molecular assay and how it works? As I was mentioning, that this virus is about 29 kilobases, and it is the largest virus we have seen in COVID family. And number two, it has many different regions. The spike protein is a spike region, or spike protein is the most virulent place, and that's where most of the mutations happen. But there are ORFA 1 region and ORFA B region and other regions which primer sets can be designed, and they can be run on a PCR machine. Like first, this is an RNA, so RNA is converted into DNA, and then DNA is run in a PCR amplification plot, and you can see that you can cut off your cycle wherever you feel comfortable that this is your CT value according to that kit available, and you can run 1, 2, 3, or as many. And because after a certain cycle, this PCR just does not move forward in amplification plot, and you have to decide your cutoff value, and anything which is amplified before that cutoff value is called positive, and any samples amplified after or not amplified at all will be called negative. There are many other technical issues can happen, but this is the basic structures: designing a primer and running it into PCR machine. So then there is always a question: which assay is important? Is COBAS assay is better than, say, PerkinElmer assay, or PerkinElmer assay is better than Abbott assay? And what are the different issues with different assays? So what we believe, this is a published data, and what we believe that every assay will detect this virus, even if it's one set of primers, two set of primers, three set of primers. You can design it the way you want. You can use the kit, which is more, workflow is more efficient in your lab, which is more valuable to you, but on financial point and on patient-based point and number of tests you do. But all of the primer probes that used in quantitative RT-PCR assay can detect SARS-CoV virus. And these are the primers which people have published and are available. Important difference exists between the analytical sensitivity to detect low amount of virus and the detection of false positive. So that's something is common to every assay. Whenever you develop a new assay, it depends. There are so many variables. Variables are, for example, you have sample collection variables. You can have a lot of sample or very little sample. You can have a sample which is contaminated with some other material or viruses or not. You may have that sample stored without viral transport media for too long, and it's not an optimum sample type. And then your transportation time from collection to the lab may be very long, and that may compromise the sample type. So most common variable is really sample, and then all of these assays are appropriate for virus detection as long as limitation of each are recognized by the operators. So what PCR test means? A positive RT-PCR test means that it is very likely that you have COVID-19 virus and presumed to be contagious. The result can tell you when you were infected or how severe your symptoms are likely to be. And there are many variables too also, that younger people have less symptom, older people have much more severe symptom. Diabetic, for sure, glycemic control, if it's not in tight glycemic control, will have a severe symptom. That's a paper published a few days ago. Negative PCR test means it is likely. So the important point here I want to mention that a positive test means that you are contagious. You better isolate yourself. If you love your family, if you love your friends, stay away from them. That's the message I've been sending them. The negative PCR test means it is likely you are not infected at the time of test. Remember that. So if you are tested 3 days ago, that doesn't mean that you are not positive now. So for example, many airlines have doing this, that you have to have tested 96 hours ago and bring that test and then you fly. But remember that if you have symptoms, that may mean that you have developed, or anyone who has symptoms and a test positive a few hours ago or 2 days ago can still be infective. So it is a good thing, but it's not a perfect thing. However, you can still become infected later. If you currently have respiratory symptom, a negative test may mean. So remember this also. If you have a respiratory symptom, short of breath, sense of smell, lost sense of smell, for example, a negative test may mean that you have something other than COVID virus, right? For example, influenza. Another possibility is that there is not enough SARS-CoV virus in the specimen to be detected. This may be due to either a poor specimen collection or because it's too early to detect the virus. So these are the issues you have to know about positive test and a negative test. And this is the data which I can share as a slide with you guys also. This is what to if you have two targets, many of the labs or regions in US and world are using two targets, target one, target two. This can be any other target. So if both targets are positive and your controls are positive, your virus is detected. But what if one target is positive? I don't know if your reports give you this information or not. But I would say uh, in cases of negative and positive both, I would say US is required to have reporting both targets, not just end results, but targets. So if one target is positive, one target is negative, that may mean that the second target not have enough virus to start template to start with for testing. All target results are valid. Results of SARCO, we call this as positive in US because one target is positive, but we ask for another test in few days with a better sample volume. Same thing is if target 2 is positive and target 1 is negative, we do the same thing. We call it positive, but we ask for another sample type after a few days. So if both targets are negative, tests are negative. If one of the target is invalid, so invalid is very different than negative. Invalid means your machine did not work properly, or your primer did not work properly, or your test methodology did not work properly for the one target. And all target results were valid results for SARCO. In this cases, we call it not all target results are valid. Results for SARCO COVID RNA is detected. We call it detected. If one target is positive and one is invalid, we still call it positive, and vice versa. And we do the testing. So the trend, what is coming down is that even if one target is positive, we treat that patient as positive, and then worry about it after 2-3 days if it's real positive or false negative. But if both targets are invalid, for example, then we discard that assay and we ask for new sample without reporting or invalid result or indeterminate results. And same thing is with the negative samples. If it's one target is negative and one target is positive, we call it negative and then do the testing again if the symptoms comes. So this was PCR assay. Now we're going to serology assay, which is antibody testing. The first FDA emergency use only for serology test was granted to Cellex on April 1st. Quantitative test for SARS-CoV-2 IgM and IgG antibody in patient's blood. So this is a blood-based samples. Then the other testing like CRISPR or antigen detection are coming forward, and they're not in wide use, but antigen testing is becoming very common because it's easy. It gives you target of M, G, and control, and if all threes are lightening up, you know that the assay is working well, and it will give you positive or negative results. So what is antibody test? What it means? Antibody testing means that you were infected with SARS-CoV at one time. Timeline can be anywhere from few weeks, 2 weeks or more, to 8 weeks, 10 weeks, a year. This may also mean that you are immune to the virus and may not get the severe symptom again. That's a good thing. However, COVID-19 is a new virus, and there are still unanswered questions about whether a previous infection provides immunity, and if so, for how long. There are still studies on there. It's not that there'll be more data coming out on that. So what does the negative antibody test mean? That your immune system has not produced antibodies to the infection, which likely means that you are not being infected with SARS-CoV at present so far, or at least 2 weeks before. 2 weeks before. You can have a negative antibody test if you are tested too soon and your body has not yet produced enough antibodies. The CDC says it takes up to 2 weeks to produce detectable antibodies, and it can take longer in some individuals. So, when to get tested? Molecular test should be done when you have symptom of infection or have been exposed or in close contact with someone who is positive. Everyone should not be going out and getting a molecular assay. That's what the recommendation is in US. Antibody test when you had or suspected you had COVID-19 and wants to know if you have antibodies to the virus. This is also used antibody surveillance purposes. So this is just a graph of showing that before symptoms of symptom onset, detection is unlikely in most cases. But in this virus, SARS-CoV is you can have proceeded for the high virus count without any symptom. So it can be positive without any symptom also. So once the symptoms are on, you are positive by PCR, which takes almost a week before your PCR test is positive. And then the antibodies develop, as we said, after 2 weeks, close to 2 weeks. And after that, PCR will become negative and antibody testing will become positive.
Dr. Rizwan?
Yes.
Sorry, do we have a few more slides? We really have lots of questions from the audience,
sure.
So I would love to.
I'm going to skip few things, but let's see if we have something. Yes, I think discussion will be much better. So we can talk about this, how the test frequency is positive, why it is important, but and FDA just approved a pooled sampling testing recommendation that how we can do that. And then so what type of testing in future is needed before we develop the vaccine? I believe that you have to have a multiplexed COVID-19, at least influenza A and B plus other viruses if possible. How long you can be contagious, and it's been really bad. And herd immunity, if there is a question, we can go about it. We can talk about it. And concluding remarks are really, China has been a number of, is to remember that many of these new viruses have coming from China, unfortunately. So what is needed really, monitor farm animals and pet cats for infection with COVID-19, since their ACE receptor responsible for COVID-19 binding differs in only a few amino acids from human ACE receptor. So any animal whose ACE receptor are very similar to human can be a carrier for this virus. Global surveillance of network involving veterinarians, animal biologists is urgently needed to monitor and possibly to predict potential sources for the emergence of another highly pathogenic COVID virus. Concept of One Health to facilitate scientific exchange across discipline, sharing of data, coordinated effort in order to prevent future outbreaks. So I end, and let's have some dialogue and see what you guys think and what's happening in Pakistan. And I need to learn some things too.
Thank you so much, Dr. Rizwan. That was an extremely informative presentation, and your experience with COVID testing in the United States. So I'm going to start, I think Dr. Rana also alluded to this earlier on, and that is the issue regarding indeterminate results. Now, what I realized, there are one or two questions about this from the audience, but one thing I was wanting to do before I go to that question is to have you perhaps define for us the difference between an indeterminate result and an invalid result. Is there a difference between the two?
So invalid results mean that one of your control or one of your target did not work properly with the testing, with the setup you have, right? Invalid is very different than so if your controls are not working, it's an invalid result. But indeterminate means that you have, for example, if you have indeterminate in our lab means two different things. One is if one target is very positive and the other target is not amplified. So that can happen because of many reasons. First, there may be a sample issue very commonly. But second target may have mutated. So if the DNA sequence for that second target has mutated, it will not amplify. You will only have one target coming positive for the second time also, for example. So we call it positive if only one target is amplified. If you remember when WHO started this testing, they were only amplifying one target. And that's why US said that we don't want to use that technology because you're only amplifying one target. But one target amplification is as good as target amplification. It just gives you a little more sensitivity, a little more certainty, but virus sequence is virus sequence. If all your controls are working and you are seeing virus either one sequence or the second sequence, that means virus is present.
And what about where the CT value is greater than your cutoff? And I mean, you know, I think Zara's also going to talk about the cutoff and verification and validation of assays a little later on. But maybe we can come back to this question when she's done her talk also. But so the high CT value is also considered an indeterminate result. And I think a lot of people would also like to know, how does one, especially when you resample and you get the same result again, is this a reportable result?
So good question. What is CT value? CT value really is determined by the people who develop this test and say that with that amount of sample or template, we call it. In DNA terms, you call it template, but basically it's a sample. How much viral copies of the sample, how many viral copies you have present in a sample which is going into PCR. And if you keep amplifying something, sooner or later, it will be amplifying for some or the other reason. Or it will become plateau and there's no amplification after that. So CT value is basically tells you that, and I'm sure there are many more expert on that. You have to cut off your CT value because otherwise your results are just not results. It's PCR amplification can happen. And some assays have 20 copies of virus, and they have shown that at certain CT value, you will have, CT value also tells you viral load, as we use in, for example, in HPV and HCV and other viruses. Lower the CT value is, earlier the amplification is, higher the template is for that virus or that sequence. So having a CT value is very important, but you need to know that what you can determine your own with the dilution of samples, or you rely on the manufacturer saying that we will cut off, our assays cut off value for CT is XYZ, 32, 34, or 40, whatever you want to do.
So there is a question here that how do you report presumptive positive results, because it creates a lot of confusion in terms of management of patients. Right. And do you have any guidelines in the United States how to do this?
Right. So what I can say that important thing to realize is this, that if you're using two target amplification system, if your one target is positive, we call it presumptive positive. And if both targets are negative, then we call it negative. If one target is invalid, we say that presumptive possible, and the second sample is requested type of thing. But the gray area the gray area can happen because of three important reasons maybe. One is sample collection, issues with sample collection. Number two, your PCR reactions or the ingredient you are using or enzyme you're using. And number 3 is basically for the DNA sequence has a mutation for RNA. And if there is a mutation, that primer will not bind and will always give you invalid results or not amplified.
So we have I mean, you've brought out a very, very important point about the PCR conditions as well. And there was another question from Dr. Sabiha where she's asking that if you've got an assay that's actually in one reaction trying to amplify 3 different gene targets, are you more likely to get, and you know, she's asking about the increased, although your sensitivity is better, perhaps your specificity is compromised. But perhaps do these assays have more of a probability of indeterminate results because maybe you're just running out of reagents or something?
So we see that in any other PCR reaction, right? So it's not something new, and it's very common that enzymes do deteriorate very rapidly. And you know, when you pipetting enzyme from one well to the other well, sometimes people do make mistakes and they do not pipette it properly, or machines can make mistake also if it's automated system and it blocked somewhere in the middle. So the enzyme deterioration, enzyme what you call not having an enzyme or sample type, or all these 3, many different things can happen because of. So the difference between negative and invalid is different, right? Negative means your system worked properly, but virus was not, templates were not present, so it is not detected.
Okay.
If it's invalid means there is some systemic error in the processing which caused this issue.
Okay, great. And there was a question before I go to Dr. Rana's, which is actually related to the antigen test. One last question about the molecular testing. It's from Dr. Ramina, and she's again asking that how would you? Sorry, I've missed. Sorry, I'm trying to get to Dr. Ramina's question here. 1 second. Yeah, I think I'm trying to go up to the question, but what I think what it was related to was, again, if you've got 2 targets and one target is amplified and the other isn't, and especially if it's the E gene and the E gene is showing a CT value greater than 38, is that how would you report that? And I mean, even on repeat sampling, you get pretty much the same result.
Right. So you know, are you saying that you use 2 different CT's values for 2 different targets? So
she's saying that do you consider? I think what she's asking is that would you consider it a presumptive positive if the CT value is greater than 38? That's the question.
You know, CT values are like black and white. That's why they are CT values. So anything amplified after that CT value, we will not call it positive.
Okay. All right.
Repeat testing, yes. You better sample volume, yes.
Yeah. I mean, there was a great study published I think a few weeks back, and they actually had a very large cohort of patients that they repeat tested, and in that their indeterminants, they found more than half of them, so over 56% of them on repeat testing came out positive. So these were your greater than 38 CT value cases to begin with, but they were resolved because resampling, actually they were positive, so that was fine. But I think that I think we can carry on with these questions, but I want to just go to Dr. Rana's because that's actually about antigen testing. So she's asking if we don't know how long immunity lasts against SARS-CoV-2, how are antigens being selected for vaccine development?
So they are selecting, again, conserved areas for virus sequences, and actually most promising vaccine so far is RNA virus. So they're just injecting RNA directly to patients with some vectors and some vectors which dissolve when they go into blood. They're still working on it, and then that virus sequences develop antibodies towards those sequences, and so it's so. 2 questions. One is that how long it lasts, no one knows. So far, it is only 3, 4, 6 months, and it is positive. People who are positive, they are positive. It also depends how much your viral load initially was to develop that immunity. Sometimes you may develop weak response. It also depends on humans. So for example, very good example is flu virus. We all take flu vaccines, right? Some still develop flu because your body is not developing immunity for that flu. So it also depends on your response to the antigen. But antigen, like spike protein, is a very virulent, very active protein. It mutates a lot, and that's what you see in different regions of the world. That somewhere it's very heavily infected, some are not. Severity is also very depending on different regions and on preconditions and age and sex. This is a sexist virus.
It is. It
Affects
seems to
more
be.
males than
Yeah, probably
females.
definitely. And I could actually comment on that a lot, but I won't in fear of upsetting all of our male audience. But thank you so much, Dr. I'm so sorry to cut this short. It's great discussing this with you, but maybe we can carry on after some of the other presentations, because this is all a very linked discussion. And I need to move on and hand back to Dr. Sabiha so that we can move on with the other presentations. Please stay with us. Because I'm sure we're going to come back and ask you some other questions after some of the other molecular presentations.
Sure.
So thank you so much, Dr. Rizwan. Thank you
My
for being
pleasure.
here today.
Thank you.
Yes, so thank you very much, Dr. Rizwan. It was really a very enlightening presentation from you. Now we have next presenter, Dr. Fatma Kenani, who is the chemical pathology and section head at in this hospital. And she's been doing a lot of kits evaluation and validation for the antibody testing. So she'll be sharing her experience. So we have a very good sharing experience from her. Over to Dr. Fatma Kenani now. Yeah.
Assalamu alaikum everyone, can you hear me? Am I audible?
Raise hand.
Yes, ma'am. Can you hear me, everybody?
If you can hear Dr. Fatma Kenani, just wanted to confirm from the audience.
Yes. Okay, I'll try and speak louder. Antibodies testing, that has been the key word, buzzword around lately. Dr. Rizwan has briefly touched upon some of the aspects, and let me see what more I can add to it. So I have no disclosures. This is going to be the outline of my talk. I will briefly discuss the basics, and then we will move on to the problems associated with the antibody testing. So, as you know, that the different tests available can be broadly divided into the direct and the indirect. The molecular tests, basically the RT-PCR, detects the genetic material, and the antigen tests have also been launched lately. Serology, or the antibody detection, is more of an indirect way to assess whether the person has been previously exposed or infected. The basis of serological tests, you all know that the coronavirus has a single-stranded RNA, and then the proteins which are there are the S protein, the spike protein, the nucleocapsid, the membrane protein, and the envelope protein. The nucleocapsid protein is the most abundantly expressed one. That is why the antibodies developing to it would be the most sensitive. The assays based on the nucleocapsid proteins would be the most sensitive ones. The spike protein has different domains, S1 and S2, and the receptor binding domain of the spike protein is the more specific one because the RBD is not shared across the different coronaviruses and are more specific to the SARS-CoV-2. So the antibodies to it will be more specific. The different kind of antibody tests, you're all aware that we have different methodologies. First one is the basic lateral flow assays, the rapid test. Then we have the microplate ELISAs. We have immunofluorescent tests, which would give a digital readout based on the immunofluorescence. And then we have the automated chemiluminescence analyzers. So considering the fact that you have different antibody types, that is IgG, M, A, or total, which are the tests which you are doing, then the fact that you have different methodologies, the fact that you have different epitopes which you are targeting, the different antigens, whether it's S or N which you are targeting, and then the various sensitivities and the specificities of the various assays. All of this make a lot of variability in the assay performances of the various tests. Then there are some functional assays, the neutralizing antibody tests, which are not yet commercially available. The dynamics of the antibodies also briefly touched upon by Dr. Rizwan. It said so that the most sensitive and the earliest marker are the total antibodies, rightly so, because it has a combination of G, M, A, whatever. IgM and G start to rise. They can rise as early as the first few days up to a few weeks, 2 to 3 weeks. And usually G follows M very closely. The antibody levels peak around the 2nd to 3rd weeks, but in some patients, the plateau or the rise can be much later. Antibody levels can also wane over time, and in some patients, the initial rise is a bit delayed. The antibodies response varies with the disease severity and the viral load. Patients with more severe disease are shown to host a greater and a earlier antibody response than the ones who are asymptomatic or mildly symptomatic. And it may not appear early on in the disease for many patients. Immunocompromised patients, again, will have a different host response. So there's a lot of variability from patient to patient when you're considering the antibody response. Coupled with the fact that there is so much variability in the assays, all of this makes interpretation of these tests very complicated. One thing has to be made very clear, that all of the tests which are routinely and commercially available in the market, these are all qualitative so far. There is no international reference or standard, so quantitative tests are not yet freely available in the market. Quantitative ELISAs are just beginning to be launched. We have not tried out any so far. And the signal cutoff values which you do get in the automated assays and even the ELISAs, they are not claimed to indicate any quantity or any concentration by the manufacturers. They're not claimed to have any correlation with that. Some of the studies have used these signal cutoff ratios in their results. These are basically studies from China and elsewhere, but they have mainly sort of validated their own assays, and these assays are not available commercially, at least for us. So for us, so far, all these assays are qualitative with a yes or a no, and they do not correlate to the concentration. So what are the problems with the antibodies test? And what does it tell us? All it tells you is that you have been exposed and you were infected with COVID-19, provided this was a true positive. Because there's a lot of issue with the specificity of the test as well, and there can be a cross reactivity with other coronaviruses as well. And what does the antibody, what does it tell you? It does not tell you if you still carry the virus, if you're infectious, how long ago were you infected, like even if it's M what you are doing or G. It does not tell you whether you were recently infected or you were infected in the distant past. It will not tell you. It will not tell you if you're immune to future COVID infections, because we do not know from now up whether or not it confers immunity. And as I said, we do not know the antibody concentration depending on this test. The quantitative assays are going to be in very soon. There are those that some of the manufacturers have launched and already launched internationally, and they might be coming up very soon to us. They're in the validation phase. But so far, the commercially available assays available to us, these are all qualitative. So if it's positive, you do not know if it's a true positive, and if it is a true positive, you still do not know whether you're infectious or you are immune, whatever. And what if it is negative? It will still not exclude the SARS-CoV-2 infection. If it was a negative test after you have recently been exposed, then maybe the antibodies have not been developed yet. Maybe the antibodies have been developed, but your assay kit is not sensitive enough to detect those antibodies. That means antibodies are below the level of detection of the test, limit of detection of the test. It could be that the antibodies have developed and then declined over time if certain of a time limit has passed since you have been exposed. So you do not really know anything, right? So if the positive test does not tell you anything, if the negative test does not tell you anything, what is the clinical utility? One thing is for sure, it is not to be used solely as a diagnostic test. You cannot make your clinical decisions solely on this test. Yes, it can be used as an aid to clinical diagnosis in very limited scenarios. That is, for example, you have the clinical and the radiological evidence of infection, and your swab PCRs are coming out negative repeatedly for due to whatever reason. You may consider doing an antibody test to build up on your diagnosis. Epidemiological studies, surveillance, yes, it is important to know if the community at large, the population, has been exposed to the virus. If there is, what is the seroprevalence in the community? It is important to know that. Again, you have to be sure that you're using a kit which is good enough for that purpose. To identify donors for convalescent plasma therapy, yes, Dr. Tahir Shamsi will be speaking more about that topic later on in the seminar series. Immunity passport, as I said, we do not know from now whether the antibodies confer immunity to a certain individual and whether we can use it to make decisions based on the antibody, whether or not he or she is allowed to go back to work. We are presuming that yes, to a certain extent, till a certain time, immunity would be there, but we cannot say for sure for how long or how much. Whether or not the person can be reinfected, we do not know. And of course, it's used in research to find out more, because the COVID-19 or the coronavirus is a new virus. We don't know much about it. So initially, when the antibody test started coming up, there was a mess in the market. The market was flooded with all kind of antibody tests. The reason was that FDA had allowed initially for companies or manufacturers to launch their tests in the market without proper validations, without an EUA was not required for them to market initially. Now FDA does require, but initially with very little validations, poorly performing tests were out into the market. The multinationals were a bit late in launching the automated tests. And their validations, their studies were relatively better than the ones which were out in the market from X, Y, and Z. These are the claims which a manufacturer submitted to FDA in order to get the EUA. You can see, I just mentioned a few, and this is taken from the FDA website. You can see that Roche has performed the sensitivity on 29 individuals at day 14. When they said 100% sensitivity at day 14, their N was just 29. Their specificity, when they were checking for false positives, that was pretty large, 5,000. Similarly, Abbott on Architect had, they did the sensitivities on 88 and the specificity was done around 1,000 on Architect. On Alinity, it was a bit lower. Similarly, you have the values for the other big players in the market. The other term which you have to be aware of is the positive predictive value and the negative predictive value. What does this mean? Positive predictive value is the probability that when you get the test positive, the antibodies are positive and you are just a true positive. And similarly, negative predictive value is the probability that individuals with a negative test are actually truly negative. Now, this positive predictive value and negative predictive value takes into consideration the prevalence of the disease in the population. So not only your kit, your assay has to be sensitive and specific enough, but it is also the prevalence in the population which is important to determine the value of the test. We do not know the prevalence of COVID-19 at this stage, and prevalence will be different in different areas. But all calculations of PPV and NPV have been done keeping in mind an estimated prevalence of 5%. Now 5%, if you say a prevalence of a disease is 5%, it means that out of 100, you will have 5 true positives, 5 cases, because the prevalence is 5%. Taking a size of 100, you would assume that you have 5 people who are truly positive for COVID-19. But if the specificity is, say, 95%, that also means that 5% of the individuals or 5 individuals are false positives. That means you would get a total of 10 positive results out of 100, out of which 5 would be true positives, 5 would be false positives. So a specificity of 95% with a 5% prevalence means that half of the time you're giving out wrong results in your positives. Just to make it clear, if your prevalence is low, that means disease prevalence is low, that means there's more chance of true negatives being out there in the population. True negatives, that means your negative predictive value is high, and there is less chance of true positives being out there because your prevalence is low, so your positive predictive value goes down. So the CDC says that when choosing a test, you should choose one which has high specificity so that you do not give out false positives. And to make up for the sensitivity part, they are suggesting that you use an orthogonal approach, which means that you at least do 2 antibodies. This is, I'm sure, not very feasible for most of us. In fact, I think all of us. But this is one way to get around the fact until we get better assays in the market, and we know more about the prevalence. So when you're validating the test, there are a number of things we have to consider. Sample selection is of utmost value because right now, whenever we're doing the validations of antibodies, we are taking the gold standard, the PCRs as the gold standard, because that is the only thing we have at the moment. But PCR are totally different from antibodies. They are detecting the antigen, and what we are doing is the indirect way of indirect detection of the previous exposure. We are detecting antibodies. Again, we have also seen in the previous presentation that PCRs can have different sensitivities. The analytical performance of PCRs, different PCRs which have been used in different studies, are different. The PCRs can be false negative because of the improper sample collection, improper timing, and technical problems. So our gold standard itself is not the gold standard, and we are judging our antibodies against that gold standard. So we have to be very sure that we are selecting true positives and true negatives when we are comparing, when we are validating our antibodies. For this reason, we should definitely include some samples from the pre-COVID times, so that even if those pre-COVID time samples would be surely truly negative, and if an antibody kit gives a positive result on that, there is definitely some cross reaction. So pre-COVID time samples should be there in the validation studies if you can manage. Then another thing would be to have similar sample set on which you would run on the different kits you are trying to validate. Because as I said, there is such a lot of so many kits in the market, you have to pick and choose depending on your scenario, whether you're going to go for a rapid test, whether you're going to for an automated test, whether you're going to go for an ELISA. You have to really and truly judge the kits and do the validations for them. You cannot wholly and solely rely on the manufacturer's claims, because they, as I showed you, they have not done extensive validations. These were the multinationals, the kits which are available in the market from China and other places. Their performance has been even poorer. So you should have a similar sample set to test out all the kits so you can verify which one is better of the lot. The numbers on which you should test should be large enough to have power to your study and to have strong results and to have confidence in your study. A small sample size would not really give you much information. You should try to include patients of similar disease severity in your sample selection. That is, if you have some patients who are mildly symptomatic, some asymptomatic, some severely ill, if you combine all of these patients, there will not be a homogeneous match. So this is preferable. It will not always be possible, but it is preferable. And then you should have samples at different days post PCR or post onset of symptoms, because we discussed that in some, the antibodies would rise over time. So very earlier on, the antibodies would not have developed, patient would not have seroconverted. So the sensitivity in the initial days would be less because the antibodies have not yet developed, not because the kit is not sensitive. And after 14 days or so, the sensitivity should rise because most of the patients have converted, seroconverted. And this is the similar point when we are saying that we should have a homogeneous patient mix, because the patients who are admitted, patients who are severely ill would mount the antibody response sooner, and the outpatients or the asymptomatic or the mildly symptomatic patients might launch the antibody response later. So you would have a variability in your population. But this is as much as you can do. It is not always possible. Like we could not manage this, as I'll tell you later. Then when you have these sample sets selected, you should make aliquots and freeze and avoid repeated freeze-thaw cycles, because that would affect the sample integrity and your results. You should have at least 2 independent readers to reduce inter-rater bias if you're talking about the rapid tests. So what are the verification checklists? What all you should be doing depending on what you're using? Sensitivity, specificity, I already told you. This will be against the gold standard PCR right now. Later on, when you have a good validated antibody test, you could use that as your gold standard. Precision, if you're using the automated assays, you would like to do precision. You would do cutoff verification. You would take samples near the cutoff, very high negatives, very low positives, and at each level you would run a minimum of say 20 samples, and that would also give you your precision and cutoff verification in one go. The samples which are high negative, for example, if your cutoff is 1 and you take samples from 0.8 to 0.9 signal cutoff values, 95% of them should remain negative. Similarly, the low positives, if you take samples from 1.1 to 1.2, 95% or more should remain positive. And your cutoff samples, those at 1 at the cutoff level, should half of the time give you a positive result, half of the time should give you a negative result, should remain around 1. So that is how you would verify your cutoffs, and you can also check your precision by the same exercise. Matrix effects, if you're talking about the rapid tests, some of them, these are rapid tests are mostly used in the field. Field workers require these, and they do it on a finger prick on whole blood. So if you're doing the validations in the lab on serum, you also have to check it on whole blood, because the field workers are going to use it on the whole blood sample. Interferences, you have to check for interferences for cross reactive antibodies, and there's a whole list of them, how you should check your interferences. I'll be talking about it. Analytical sensitivity, this is different from the sensitivity of the test which is there in the first row. That sensitivity is the clinical sensitivity. Analytical sensitivity means the limit of detection of the assay, how, at what levels, what would be the quantity or the level at which the test will pick up the antibodies. Right now, since we don't have a quantitative assay, we will not talk about the concentration. But for example, you can take a single sample, a single positive sample, and run it on various rapid devices with dilutions, and the device which gives a positive result on the greater dilution would be more sensitive than the others. When you have a quantitative assay, you can do it in a more objective way. So the cross reactivities or the interferences, when I said you should include pre-COVID samples if possible, you can also, it's almost a wish list, but if you could get these samples which have potential cross reactivities to COVID-19, it would be best. These would be samples which have a high acute phase response, inflammatory response, prothrombotic states, autoimmune antibodies, ANA positives, renal failure, RA antibodies positive, RA factor positive. So all of these patients you would like to test to check out if your antibody kits are giving any cross reactivity or interferences with these. Also the HIL, that means the hemolysis erythrocytemia, which we do in all the assays as well. If you don't have pre-COVID samples with all of these interferences, you can do PCR negative controls and see if you have patients who have high CRP or high troponins but unrelated to COVID. So what we did was we took around 235 samples. We had 100 negative samples. 50 were confirmed PCR negative samples, and 50 were fresh frozen plasma samples from pre-COVID time, from June to October 2019. And the positive samples, 135 PCR confirmed COVID-19 samples. They were divided into 3 categories, depending on days from PCR. On one particular sample, on one particular kit, we could do lesser number of samples. We did around 6 ICTs, 1 immunofluorescent, 2 ELISAs, and 3 chemiluminescent assays validation. The results, I cannot share the details, but briefly what we found was that the ICTs had a broad range of sensitivity, ranging from 30%, as low as 30% to up to almost 80%. Specificity was not bad, between 98 to 100%. Best performance kit amongst the ICTs had almost 80% sensitivity and specificity of 100% on the samples tested. And this is the kit which right now our global health team is using in the community. The ELISAs somehow had specificity lower than the ICTs, but the sensitivity was higher. Immunofluorescent test, we used only one, the sensitivity was good, but the specificity was very low. Chemiluminescence assays, we had two which had very good sensitivity and specificity, better than ELISA, but lower than the claim, and similar sensitivity at day 14. There were certain limitations. We had to take samples from a combination of inpatients and outpatients, although this is not what I recommended, but this was because we did not have the samples from inpatients for over 14 days and all. And as I said, the comparative method is imperfect. We could not do interfering antibodies or in all of this. We plan to do in the future. And all experiments could not be conducted for all the assays. So the way forward is that I think we should collaborate. Similar techniques used by different labs. We should collaborate, fill the data, and then fill in the gaps in the validations, because this extensive validation is not possible for every lab to do on its own. That's all. The take-home messages: antibodies should not be used as a diagnostic test. Routinely available tests are currently all qualitative. Use a very well-validated assay, and selection of good samples is crucial for proper validations. Thank you.
Thank you, Dr. Fatma, for a very comprehensive presentation on antibody validation. I'm sure you have done a lot of work over here. There's a question over here by Dr. Sabahat, that if the COVID-19 is declared pandemic, why the prevalence is 5% considered for calculation?
Because we have not really done extensive testing on the individuals, we do not know at large. This is the prevalence which has been taken for now, and as more studies on seroprevalence continue, I'm sure this will change. This is an overall prevalence taking into account the low prevalence areas as well as the high prevalence. Prevalence would vary in different areas.
Okay, so I mean, considering the validation that you have done, what do you think? What should be the testing algorithm if you are going with antibody testing in the community?
I think you should be doing the antibodies. At the time being, the antibodies would only be used as a marker for seroprevalence. Whether or not it's positive or negative, you would not be basing your clinical judgment on that.
Okay.
If it is positive with symptoms, yes, you would get a PCR done. If it is positive without symptoms, there's nothing much you can do except quarantine the patient for the next few days.
So thank you, Dr. Fatma. If there is no other questions, can we move to our next presenter? And for that, I'll hand over the mic to Dr. Saeed. Dr. Saeed is the head of the Department of Molecular Pathology at Dow University of Health Sciences.
Hello, assalamu alaikum. Hello.
Yeah, hello. Please go ahead.
Okay, thank you so much. I'm enjoying the wonderful presentation so far from the wonderful speakers, but we are running short of time, so I will quickly move toward the next presentation, that is about laboratory diagnosis, validation, verification of various tests for COVID-19. And we are lucky to have a wonderful presenter with us, Dr. Zara Hassan, who is professor and consultant of molecular pathology at Department of Pathology and Laboratory Medicine at the Aga Khan University. And she has extensive experience in molecular diagnosis of infectious diseases as well as in immunological disorders. She has set up the COVID-19 diagnostic lab and at AQH, and has been involved in validation, verification of molecular tests of SARS-CoV-2 during this pandemic. She will share some of her experience and updates regarding this test and modalities for the virus identification. So over to Dr. Zara Hassan.
Assalamu alaikum, everyone. Thank you for the introduction, Dr. Saeed, and I want to thank PSI and Dr. Sabia for putting together this effort. Dr. Rana, thank you for having this joint seminar, because this is something that we really needed to do, and your team put in the effort to put it together. I realize that we have already had an introduction to molecular diagnostics. A very comprehensive talk was given by Dr. Rizwan Naeem. So what I will do is I will talk about molecular-based testing for SARS-CoV, and I will try and fill in the gaps that have been raised, some questions that have been raised through the chat I've seen, and a couple of things that came up which needs some, a little bit of discussion regarding how you would go about validating and verifying tests, because we are in a, 5 months from the pandemic. We know that, this is an extraordinary circumstance. Our first case was diagnosed on February 26th. Those of us who have followed it know that initially it was just travelers, and the numbers of local transmissions have just grown. And now the situation in Pakistan is that even though it doesn't have high death rates or case fatality rates that are close to what has been seen in Europe and in the US, it is a rapidly growing pandemic. And we have, we're testing thousands of positive cases each day. We still have almost 100 deaths each day. We are in Sindh. Sindh is the most affected province at the moment. Karachi has a population of 20 million people. And you've heard from Indus Hospital, who is very, very involved in diagnostic testing for SARS-CoV. Dr. Said's group at Dow University has also been contributing to the daily tests that are being done, not only for Sindh province, but we get samples from all over the place at AKU. So I just, before launching into specifics about tests, I mean, this is the latest stats from Karachi, where we, on average, 12% of tests remain positive, but it's highly variable across cities and it varies from day to day. And we're continuing to see a couple of thousand or more positive cases each day. And the question really remains, what is the bottom line? Because until you have sufficient contact tracing, most of the testing is based on identifying symptomatic individuals. In fact, most of the testing is testing of symptomatic individuals, while ideally it should be used for case detection. It should be used to identify SARS-CoV infection in asymptomatic individuals, so that we have an idea of exposure and we are able to actually understand what the prevalence is in the population. But we don't have that, and that's why the testing is so tricky. And we don't understand where the numbers are going, but we can only do our best. It's a resource-limited setting. As Dr. Rizwan pointed out, Pakistan has scaled up enormously, like many countries weren't able to. Because of the collaborative efforts of the public and private sector and the efforts put in by governments and also private institutions. So if we look at coming to where molecular testing can be used, and we come back to this slide, which is a schematic, and it tells you that the kinetics of the virus and the period in which virus RNA is present is related to the period in which the PCR, which is the blue line here, can be useful in diagnosing it. So we say that the PCR can be used to identify RNA. So it can be used to identify virus infection in asymptomatic individuals, which becomes important because transmission, as we know, is through both symptomatic and asymptomatic individuals. However, there's a window period in this, okay? And then there's the other question as to how long can you capture the virus through RT-PCR after a person is symptomatic. This again is something we continue to learn about, and certainly virus shedding for a week into symptoms is the most infectious phase, and now studies are showing that while this PCR positivity stays on for a while, there are studies to show that, you know, a couple of weeks later, where you have less viral load or you know, signified by higher CT values, in fact, you are looking at virus that's less culturable. So, and within that space, of course, there's the, you know, the antibody detection. But I'm going to talk about the period in which you can use your PCR to detect virus RNA. So screening remains important. I think this has been brought up before. If you have symptoms, the symptom list keeps growing. Initially, there were respiratory symptoms, and now the list of symptoms is increasing. Two issues are very important. One of them is sampling, and the other one is testing. And in my talk today, I will say a couple of things about the respiratory sample, because what you test depends on how good your sample is. And downstream, it doesn't matter what you've done in your PCR. If your sample is not good enough, then you will not get an appropriate result. Secondly, for testing, we have been focusing on PCR testing for individuals, whether they are asymptomatic or symptomatic. But moving forward, there are also recommendations in some cases to where it can be done to improve efficiency of testing using pooled PCR. However, there are many caveats to that related to the technical manner in which this can be done. So I will spend a few minutes on that. So your appropriate sample for testing is classically the upper respiratory specimen, because it is a respiratory virus, and in the initial phases it is the nasopharyngeal swab, the oropharyngeal swab, and then the nasal swab that has typically been used. And then, of course, in cases where there's pneumonia has set in, the BAL, tracheal aspirates in case of intubated patients, that those can also be used. In terms of viral load, there is some variation in the kind of virus copy load that is found in different samples. And overall, the nasal, nasopharyngeal, and the mid-turbinate swabs are thought to have the highest viral loads, while the oropharyngeal, a sample that is much easier to collect and can also be self-collected by people, has a lower load. The initial recommendations were to use just a nasopharyngeal swab, and then later on the recommendations were to use a throat plus a nasopharyngeal swab. Now, it is believed both by the IDSA and the CDC guidelines that the nasal swab itself is comparable to the nasopharyngeal swab. So these are, as we move along, issues as we know, sampling gets easier if your sample is easier to collect, because a nasal sample is less invasive than a nasopharyngeal sample. Sputum, saliva, this was mentioned earlier. These are also samples that can be used for testing. One needs to be careful about handling sputum and saliva, particularly saliva, because saliva is not a very stable sample. Because it's rich in oral flora and it needs to be kept cool, it dries up. So validation for saliva should be done separately from validation for other respiratory samples. It has been found that the virus is shed in stool as well. The significance of this is not entirely clear. Certainly, the high copy virus found in stool associated with the asymptomatic phase or the symptomatic phase of infection has been culturable. But again, after 1 week of infection, it is thought that finding RT-PCR positive SARS-CoV in stool is not necessarily associated with live virus. In blood and urine, there are not many studies that have shown that SARS-CoV is detectable. So this is just to re-emphasize what I said earlier, that both nasal samples and nasopharyngeal samples and salivas are now thought to be comparable samples for testing. Coming back to what testing we're talking about, when you have RNA as a starting material, the first step is to reverse transcribe it because a PCR is done on DNA. So the reverse transcription is a process that is inherent to RNA viruses such as HIV, influenza, and SARS-CoV. And once you have DNA, then it is possible to do a PCR for any of the target genes which are part of SARS-CoV. So it's a relatively small genome, and it has open reading frames ORF1, ORF2. It has an E gene, which is a common target. There's the nucleocapsid. And then importantly, it has spike proteins. And it's these spike proteins that are thought to be very important to its virulence. It is thought that the spike protein binding to the ACE2 receptor is responsible for the initial entry of the virus into host cells. Primers can be designed to any of these genes, and the recommendation for choosing a good RT-PCR test cannot be overemphasized. Ideally, there should be at least 2 different targets. That could be either ORF or N or E. I must say that there has to be some way of controlling for extraction, because like all RT-PCRs, we need to make sure that the sample being tested has been extracted properly. Therefore, test kits often have something they call an IC or an internal control or an extraction control that is spiked into the lysis buffer when a separate virus extraction for RNA is being done. And that, when it's amplified, ends up being your 3rd target here, or your 2nd target if you're looking at one virus target. But the extraction amplification is really important, because without that, I believe your test would be invalid. Because a negative is not a negative unless your internal control is present, and a positive certainly should not be given a positive until you're sure the amplification has worked. Therefore, there are a lot of kits in the market, and we have, over the past few months, been asked many questions by our colleagues as to what to go for. And it's a competitive space, it's a difficult space. We've all been plagued with supply issues, the difficulty of getting reagents out of regions that are responsible for producing tests, such as China, Korea, Europe, them being in lockdown. So it's been a tough balance trying to compromise or not compromise quality against what is available in the market. But I won't name any test kits today, but whatever you use should be ideally CE-IVD marked. It should have a good sensitivity and specificity, and it should be validated within your laboratory. So, you know, there was mention earlier about laboratories not being able to do their own extensive validation. I think that there's a minimum that every laboratory needs to do, because validation and verification for any test needs to be particular to the laboratory that it is used in, because what works in my lab may not work in someone else's lab. So targets, stable targets with a reference control for SARS-CoV together with an extraction control are a minimum. And then, of course, you know, I've mentioned that before. Now, if you're doing a 2-step, you would extract the RNA, there would be PCR. And I put this up here because in the changing space of moving away from, you know, your 2-step RNA extraction followed by PCR, there are now new automated molecular platforms coming out that we have heard about. The most convenient is the Cepheid Expert, and I believe that in the US, certainly in Dr. Rizwan's lab, they are running a couple of thousands of these each day. Unfortunately, it is not being made available to Pakistan as yet. The BioMirior BioFire Film Array is also an extremely sensitive test, but quite expensive. The Abbott ID Now was something that was launched in the US a couple of months ago with a lot of expectation. It is a rapid test, but it has lower sensitivity because of the way that it is used. And while it is convenient in a emergency setting, I am not sure how commonly it is used in the hospital setting, but certainly this is not yet available in Pakistan right now. What we use at the AKU is a combination of things. Initially, we started off doing our RT-PCR on thermal cyclers like everybody did. We started with the in-house LDT based on the WHO protocol or the Berlin protocol, which was a target of the E gene. And we used an internal control, which was the human RNA-P control. But the last 3 months, we have been running all our samples on this system, which is the Roche 6800, which is a high throughput system. And in this, it is a system that you just need to load your sample, and it is end-to-end result, and the results are reported through the laboratory management system directly. So that has been a huge saving of effort. Of course, I mean, there are many technical issues with using complex machines, but it does allow you to do a lot of samples, 96 samples in about 4 batches, and allows you to stack multiple batches one after the other. So it can be run through the day. I want to highlight some of the points about validation and verification and guidelines that are both College of American Pathologists guidelines and CLSI guidelines. And even if your laboratory isn't following them strictly, these are guidelines that do help a lot understand how a particular test works in your hands. So the first thing and is to understand that each laboratory must verify the manufacturer's claims, because just because you bought a box doesn't mean that everything that the kit insert says will work exactly as it should. So that's why you need, even for CE-IVD marked kit, you need to do what's called verification to make sure that the specificity and sensitivity that is claimed by the kit is in fact what it is, and you must set your own cutoffs and report according to what you find works in your lab. For accuracy, reference material from a reliable source is important. And I know that this has been a problem for SARS-CoV. We all started off, and not everybody had access to accuracy material. So initially, I know that we bought accuracy material. We obtained it for the European Virus Archive, and they provided free of cost. So anybody who wants reference material can reach out to them. They provide controls, e-gene controls, RDRP controls, and now their CAP is selling proficiency material. In addition, there are other sources for accuracy. So it's important while we are running these, a heavy load of tests, to actually have some reference material to run parallel with our assays regularly to make sure reporting is robust. So for specificity, what is specificity? Specificity is that when you have a positive result, you are reporting exactly what you think it is, that it's SARS-CoV-2 and not some other virus. There should be no cross-reactivity. In RT-PCR, the specificity is set by the design of the primers. So it'll amplify a region that is particular to that virus. A first step for setting up accuracy for your samples is that at least 20 samples should be used. Now, these samples ideally should be clinical samples that are confirmed by alternate tests. And in the absence of that, you should have full clinical laboratory and radiological parameters so that you are able to document that the test that you're using to set up as accuracy material is in fact has the causative agent that is most likely associated with that condition. Initially, when we didn't, for our first tests, when we started our validations, we used the European Virus Archive control. We also ran at least 2 different kits on the same samples to make sure that we were robust in deciding what was a positive control. And the standard way that the accuracy should work is that for minimum of 20 samples, you need to have accuracy of at least 95%, and you must include negative samples. Another aspect of verification is precision studies, and precision studies are important because it is essential to make sure that your test is reproducible. So reproducibility of samples is tested over 3 to 5 days. Ideally, it's 5 days. In cases where one is short of reagents, we have used a 3-day, and then the 3-day needs to be within a 20-day period. The testing should be in triplicates. And importantly, the test, even though it's a qualitative test, it should be across a range, because we know that even when you don't have a quantitative assay, your CT value is associated with the amount of virus you have, and you know that a high CT value means a low viral load, and a low CT value means a higher viral load. So high, low, and negative samples should be used. How do you define what is high and low? What has been published and what we used was that we considered CT values under 20 or about at least under 25 if you don't have samples under 20 as a high viral load. We considered a low viral load, a medium viral load, CT values under 35, and the low was about 38. So we also did studies for reproducibility at the lower end, which is CT 37 and 38, depending on what your cutoff is. So it's important that for every laboratory that you set your own cutoff, because the sensitivity of detection is based on the limit of detection of the assay, and this can really vary. So the way it looks at, like in the kit insert, if you read it, it'll say 100 IU per ml, or it'll say 200 IU per ml, which works out to 0.1 or 0.2 IU per ml. But if you think about it, the sensitivity works back to how much respiratory specimen you have put in the RT-PCR mixture, okay? In the extraction mixture. Your input volume for the assay, if it's 100 or 150, then that's the volume you're looking at. And then there's going to be an elution volume, which may be 40 microliters, or for larger automated extractors, it may be 100 microliters. And then if you set up the PCR, you're using 5 to 10 microliters. So there are so many variables. There's a variable of how much you're extracting. There's a variable of how much RNA you are putting in your RT-PCR. And then you need to be able to work that back to the limit of the assay. So, and that needs to be thought through specifically for each lab, because each of these tends to vary. Different labs use different kits, and then they use different mixes. So the limit of detection needs to be set for every lab separately. And LODs, once they're set, should be reproducible, which means that at the lowest limit, you should be able to test it at least 10 times in one go and find that it is consistent. Just to put out there, for the automated systems, the volumes tend to be much higher. So it's about 600 microliters for systems such as Roche, and it's about 1,000 microliters for the Cepheid Gene Expert. So you have a lot more play in terms of volume, and in addition to the convenience of actually having a end-to-end handling to output, you also have a better chance of picking up more of the sample, because you are putting in not 100 microliters, but you're putting in 600 microliters or more in each case. So now, The other thing I wanted to talk about was something that was mentioned a little bit by Dr. Rizwan, because it's being talked about now by the FDA, but the Europeans started to use it in March, April, because they were looking for a way to test their populations to try and understand the infectious rates in the population. And the idea is that if you have a low risk population and you're able to risk stratify it, then you can improve efficiency of testing by grouping the tests. But it's really important to understand the technical issues around this. And who do you group? Who do you screen? Which population should you be testing? It's certainly no good for anybody symptomatic, because you don't want to waste a test, because if you pool 2 or 3 or 4 or more tests, and you have a high likelihood of one of them being positive, then you're increasing your work, and it's very laborious, and you have to redo the tests again, so it's not efficient at all. So for example, right now with the AKU, we are limiting our pool testing to a very small cohort of people who are low-risk asymptomatic cases as a compulsory pre-screening for surgery and admissions to the labor ward. So for those who are not familiar with pool testing, the idea is that you would select a cohort of individuals, either low or medium risk. We are currently going for low risk individuals, and you would combine the samples, you would test them as a group, and if the group test was negative, you would report the negative, and if there was a positive, then you would test each sample separately and give the result. So the technical considerations, again, I will emphasize, is very, very important when thinking about pool testing, because whenever you pool, there's a dilution effect. And I've already talked about how this dilution effect can play a role depending on what your input is. So if you have an input of 100 into your RNA system for extraction, then you need to think about, if you're adding, twice as much or 3 times as much, will you be able to robustly capture enough RNA to find it representative of your samples? So you need to do it in the context of understanding the LOD of the test that you are using. Okay, so the number of samples that is pooled is dependent on the sensitivity of the system. Okay, so your system, maybe the kit, whether it's the RT-PCR kit and what the lower limit is, and if you were to dilute it, then how much would you compromise it? You need to work that out in your own lab. Nobody else can do that for you. And you need to make sure that it's reproducible, and you need to run through the same kind of validation verification that you do for a single PCR test. Okay. If pooling at the level of the RNA, this is option number 2. So for example, you pool the input. So you would put 2 or 3 samples of the same, of different specimens, and you would extract them together. That's one way of doing it. The second is to level of the RNA. But here you have additional technical considerations, because when you're dealing with small volumes of RNA and you're adding 3 or 4 times as much and you're doing a PCR on that, you need to be particularly careful that there are no technical errors. So, and that's an important message to take home from pooling, because the compromise and the additional load on the technical aspect of it is quite a lot. Now, the number of samples, given that you've dealt with all this, the number of samples that you should be pooling depends really on the prevalence of the infection. So in populations where the prevalence is less than 1%, people have made pools of 10 or 20. But currently, we don't know what our prevalence is, but certainly we are more than 10%, as it may seem, based on the PCR testing rates across the country and in Karachi, and certainly in our hospitals. Therefore, screening large batches may not be useful. So currently, we recommend that small pools of less than 5 should be used, and you see how it works in your hospital, making sure that you take into account all the other considerations. So I'll end with a couple of questions that people continue to ask about the relevance of SARS-CoV PCR testing. And the first one is, how long will a PCR stay positive in an infected individual? Where does PCR equate with viral shedding, and does PCR positivity equate with infectivities? These have remained problems, questions that people have asked, and they're all relevant. They remain relevant, but they're a little bit easier to explain now because there are some studies, and I've just got some figures here, just one now, that I'll take you through, because now there is data out where the kind of CT values have been tracked over time. We know that the CT values certainly PCR positivity can stay up to 3 or 4 weeks in individuals. In most cases, it goes down after 10 days. When these samples are cultured, after this period, in most cases, the samples tend not to be culturable. And it's similar with stool specimens, because stool specimens, after days of onset, if we look here, the red is stool specimens after up to 1 week. It seems to be that both the swab and the stool specimens are culturable, and after that, this study showed that they were negative. Okay, so whether or not it is thought that it's RNA hanging about or leftover virus, we don't know, but certainly they're not culturable, therefore they are not infectious at this stage. And we will continue to learn more about this. How does RT-PCR positivity link with culture positivity, and how does it link with transmission? Well, here we know that certainly when you have in samples that have recovered, people who have recovered compared with individuals who have not recovered, there's very little difference. And these are different targets that have been used, and it doesn't matter which target you use, the trend is the same. CT values do decrease with time, and once the CT values decrease with time, they're usually associated with less culturable virus, and certainly CT values greater than 35 now in the last literature that I have seen. Certainly the ones that are more than 35 plus are less likely to be culturable. So I will end here by just a summary slide to say that there's a lot of value for using SARS-CoV to understand both infectious and transmission dynamics for COVID-19. And there's value at the individual level because it informs on the infectious status of the individuals. It helps hospitals understand how to manage patients, and in the context of public health, it informs as to the importance of protecting other people around them. And at the end of the day, we know that the only way that we can stop transmission and the chain is by masking and social distancing. So I'll end here. Thank you very much for paying attention.
Thank you very much, for the wonderful presentation and sharing very important statistics. A good thing that you have asked a couple of questions by yourself. So a lot of questions that was expected to be asked by the audience as well, because the few of the queries about the PCR, because the results are quite confusing for some people, that if they compare lab to lab or time to time, then there are different results. So particularly this, if we have very low viral load, so there's one question asked that how we can be sure that this is towards the recovery or it's a start of the infection, like it is a live virus or it is a recovered or dead virus at the low viral load.
Yes, that's a good question, and it's always something we ask because we don't know what stage of disease they've been sampled. And this is why we don't report the CT values. And they're only useful for following serial testing. So if you have a patient admitted in hospital, to follow the trend as to what is going on with them, you can use the CT value. But you you would not report it exactly because of that. You don't know if they were just at the beginning of a pre-symptomatic phase, or if they were symptomatic, is it related to the symptoms they've had? Therefore, they need to be managed clinically and not based on their molecular diagnostic result.
Okay, there's another being asked. They are using manual kits. So they're asking that is there any difference between the manual kit being used for extraction or automation, as they don't have the automation? So any impact of the extraction process on the results?
No, not at all. Manual extractions are good as long as they're used carefully. It's just a lot of work. So if you have the manpower to do good manual extraction, then that's completely fine. But one needs to make sure that with manual extraction that you're cleaning up, you're decontaminating, that there's no contamination with your nucleic acids, because things are exposed, tubes are opened a lot more than they would be in a closed system.
Okay, another important question is regarding the pooling of samples. That should be done at the extraction stage or at the amplification stage? Pooling of
samples. I believe that if you're going to pool, it should be done at the extraction phase stage, because it allows you to work with a larger sample volume. So depending on your system, so for example, our volume is 600. So, you're playing with 600 microliters, which is quite a lot. For the manual extraction systems, your input tends to be, at least for the QIAGEN that I'm familiar with, is 140 microliters, which is small as it is. So it's really important to balance how many you can pool and whether it's worth your effort, because you don't want to be missing the low positives. So when you are validating for pooling, even if it's 2 or 3 samples, and I'll tell you that we're not doing more than 3 samples right now, even for that, it's important that you do your validations to make sure that you are able to pool and detect your low CT value samples. Because if you cannot, then it is not reliable.
2 last regarding the lab, they're saying that we are doing it BSL-2. Would you recommend us to BSL-2?
I'm sorry, Said, I didn't hear. I'm going to turn the video off. What did you say?
The question being asked regarding the safety level of the laboratories. They are doing in BSL-2, so he is asking that should we do an in BSL-2 laboratory?
So we are, it depends on what you have available. We are doing all our sampling in BSL-3 because we take our samples, our respiratory samples, to the BSL-3 lab, and we set up the samples in BSL-3, but our machines are in BSL-2, okay? The WHO recommends that you use a BSL-2 extraction hood with PPE. So if you don't have a full BSL-3 facility, that's fine. As long as you use full PPE and make sure that you have a BSL-2 hood with an exhaust. It must be, it should not be a hood which has a filter that recirculates the air. So it depends on the biosafety level 2 hood you have, more than anything.
Okay, thank you. And one is regarding the weak positive results. So he's asking that should we write on the report it's a weak positive, or should we write a repeat after some time, like 72 hours or 24 hours? Should we write like this?
So I actually do not think that we should be reporting a weak positive at all, because we should be confident that we have a positive result. And that is why you need to have your own guidelines, you need to have your LOD. So in our lab, we have an LOD of say 38, and we know that after 38, we will, if we get a positive, we repeat it. And so it depends, every lab needs to set their own guidelines for what is a reliable positive test, because by asking people to come back after 4 days, that's asking them to get an extra test. So that's a bit unfair on the patient. And in terms of weak positive, you don't know what stage of infection you have. If you're confident that this sample is positive for SARS-CoV, that's what should be reported.
Thank you. And there's like one other borderline positive. So I think you have answered the same.
I answered the thing, yes.
Okay, thank you very much, Dr. Zara. I know the PCR.
Thank you very much.
It was very interesting presentation and a lot of questions being answered. Thank you so much for clarifying many of the concepts that people were having a question about. Thank you so much, and I am forwarding toward the organizer, the most Dr. Sabiha and others, to continue with the other presentation. Thank you so much.
My pleasure. Thank you.
Thank you, Dr. Zara, for such a wonderful presentation and answering so many questions that were, keeping burning in our minds. Now I invite Dr. Nazia Khurshid, who's a consultant microbiologist and section head at in this hospital, and she is actually leading the COVID-19 testing over here, and been involved in a lot of validation of for not only for the PCR kits but for the VTM and pool testing and so on. So she is going to share her experiences with us. So over to Dr. Nazia now.
Assalamu alaikum, and thank you very much, Dr. Sabiha. Thanks a lot, Dr. Rana and PSI, for providing us the platform to share our experience. Today, I'll be sharing a little bit of the experience of the COVID-19 team at TIH. I have nothing to disclose. So we'll share the challenges and the validations done at TIH. Validation is the process of confirmation by evidence that requirement for specific application is fulfilled. And it also examines the process to check that results are consistent and they are correct. So when we have to validate the test, we can validate it before introducing into routine use the non-standard methods, or the lab, if the lab has developed their own methods, or there is a standard method which is used outside the intended scope, or when the validated methods are subsequently modified. Validations at TIH are done at various levels. We have done a few validations of the amplification kits. We have done the verification of analyzers, Abbott and Roche, Expert Express SARS-CoV-2. We have also done a little bit of pool validations, and we prepared VTM and swabs because of the non-availability of these in the market. There are different challenges which we face when we are working in the COVID lab, which include the following. Like sometimes it is difficult to procure the consumables, especially the same consumable which you have already validated, it is not available in the market. Then there is availability of lack of availability of appropriate literature with the kits. We are not sure sometimes about the targets, the literature is not proper, the LODs are not documented. Then there is a lot of variation of methodology of kits with frequent change of kits because of the non-availability. The methods are so different that the people who are working at the extraction level, at the master mix levels, they are confused. If the same kit is available all the time, it is easy to work. Otherwise, if it is changing frequently, then you have to remind the team to prevent errors. Interpretation challenges are also there. Because of the changing kits, the different CT recommendations present in related to every kit, then we have problems like contamination, which occurs in the lab. The contamination then leads to repeat testing, and then there is it is difficult to follow the turnaround time. Sometimes the QCs are invalid. Even then you have to repeat the batch. So we have problem with the turnaround time again. It is also very cumbersome to train the teams and and maintain their competency levels. Then there are hazards like biohazards. There are chances of getting infections. It is also very cumbersome to dispose of the waste. The incinerators are situated away, and you can't throw the waste just like that. You can't store it like this. You have to autoclave. You have to assign a certain space, train the team, and then dispose of the waste properly, so that the infection is not communicated to the environment of the hospital and then to the community. And there are also challenges like getting the storage space of the samples. For the negative samples, you can discard, but the positive samples you want to keep. It's a big challenge to get the freezing space and to maintain the temperatures and to store the positive samples. Now, coming back to the validations at TIH, when we started testing in mid-March, the consumables were not easily available. So we got a kit of amplification and did the validation by using the positive control and negative control of the kit. We included 20 positive and 20 negative controls and did the precision study, and it came out to be 100%. Then, because of the scarcity of the kits, we started looking here and there about for other kits available in the market, and we bought a second kit from another company. So we validated the second kit with the first one by using 58 samples. It was an amplification kit, and the agreement was 100%. The sensitivity and specificities were very good. So we included these two in our laboratory. We did validation of a third amplification kit as well, and the sensitivities and specificities were good, but the procedure involved in amplification, the methodology was very cumbersome, and the amount of internal control used was little, so it was very difficult for the team to maintain reproducibility, and we were facing errors in the results. So we stopped using this kit. We also validated the manual system with the automated system. The manual system was validated by using 40 samples, and the sensitivity for these 40 samples were 100%, and specificity and agreement was also found to be 100%. The validation of Roche was done with Abbott, and 231 samples were used to validate. The sensitivities were found to be 94.4%. The specificity was 86.6%, and agreement was 90.3%. Then we got Expert Express 1.5 months back. Few cartridges which we are using for the gynae ward and also for the surgery for the department of surgery. In case of surgical procedures done for the road traffic accidents as well, when we need the results quickly, since the reporting time is very short and the running time is just 40 minutes, so we get the results in an hour. We validated this with another extraction and amplification system, and we used 45 samples in which we included 20 negative and 25 known positive samples with low and high CT values, and the sensitivities were found to be 100%, whereas the specificity was 85%, and the agreement was 93.3%. Because of the difficulty in finding VTM and the swabs, we tried to prepare VTM at Indus Hospital, and thanks a lot to Dr. Zara. She helped us, and we utilized the WHO protocol. We prepared the VTM at Indus by using the same protocol, but we were unable to follow the same antibiotics. The antibiotics were not available, so we changed the antibiotics and utilized another combination of antibiotics to cover all possible flora present in the mouth. And we validated the sample by using 231 samples we took nasopharyngeal swabs of the patient in parallel with the commercial swabs, and validation was done by running it on the analyzers. Sensitivity was found to be 92.6%, the specificity was 94.5%, and agreement was 93.9%. Swabs were also prepared and they were validated by getting the sample from the patients and then running the PCR in parallel with the commercial swabs, and the sensitivity was found to be 91%, the specificity was 92%, and agreement was 91.3. We also did a pooled study by utilizing the extracted RNA. We prepared pools of 4, 6, 12, 18, and 24 samples, and the most satisfactory results were found to be with the 4, 6, and 12 pools. So I would like to conclude by saying that it is difficult to procure consumables and they are not up to the standard all the time. As Zara said, we have to see so many things. So we need to validate, and validation also has a cost. It is difficult to procure and maintain the availability of validated product. It's a great challenge. Therefore, validation is necessary to run the lab on standards so that we can provide quality results to improve the patient outcome. And that's why we need to share our experience in this era of pandemic. It is going to ease out the situation in the community because all the laboratories don't have the facilities. They don't have access to the resources. So they can use the experience of other organizations, and that will help us to control this catastrophe in the world. Thank you very much.
Well, thank you very much, Dr. Nazia. So anyone has question, please, you can either raise your hands or write the message. The questions coming in. So there's a question from Dr. Usman who's asking that which method was taken as a gold standard, Roche or Abbott, when we're doing validation?
Abbott. We were working with Abbott previously, so we had it. So we procured Roche later on. So we run the samples in parallel on the 2 analyzers.
So another question from Dr. Abdul Qadir. There is any reason for discrepancy between Roche and Abbott? I mean, you have shown sensitivity and specificity. So he's asking, what is the reason of this disagreement between the two? Or the agreement is 90.3%?
Yeah, it could be because of the facts that different amount of volume is taken and different number of RNA copies could be there. It could be because of this.
Yeah, I agree that there are multiple factors that are involved, but the 90% agreement is a good agreement between the two systems that we can use it. Okay. So, okay, there's one more question. Have you verified LOD of the kits?
Yes, we did.
Okay. Okay. So there's a comment from Dr. Ramina that it depends upon which instrument lab is using. We use Roche and take this as a gold standard. Okay, fine. Okay. Okay. There's a question from Dr. Asgar that government supplies every time new extraction kit and amplification kits. We in government hospitals. Okay, I think this has been answered again by Dr. Tara. So if there's no other questions, then we may conclude this first webinar session, first series of the first session of the webinar series. And all the presentations were really marvelous and very enlightening. So remember that we have another sessions on the 17th and on the 24th of July, and hope to see you all in those webinars for more interactive and enlightening sessions.
Dr. Sabiha, can I just ask one thing? Is it possible to just, if anyone's interested, to continue the discussion? Dr. Rizwan is still here. If people are still willing to stay here, just to have a bit more of a discussion about really how quickly have we been able to respond to the pandemic in terms of making molecular testing available in a number of different provinces, and could we have done this quicker? Because emerging infectious diseases, really at the forefront of that is molecular diagnostics. And unlike other countries, although we did do it very rapidly, but our test per day or our test per 1,000 of population is still way behind what it should be. I don't know if anybody wants to chip into this discussion, or you want to end it here. It's entirely up to you, but I just thought I'd put it out there.
Yes, Natasha, I mean, completely agree. If someone has anything to add in the discussion or want to ask from our presenters at this moment also, we have, because our last speaker could not join us because of some problem that was because of that he was held from giving the presentation. So we have that time, about 10 minutes time. So if anybody wants to chip in to add into this discussion, they are more than welcome. We are all muted. Okay.
I think everyone's perhaps tired and had enough. I don't know if Dr. Rizwan is Dr. Rizwan still with us?
Okay, maybe if you raise your hand, we will unmute you, because otherwise, it will be.
Yeah, I think Zara has a comment. Do you want to unmute Zara?
Yeah, you're doing it. Okay, so you can unmute yourself. We have given this command. Anybody who wants to participate, they can unmute.
कुछ ऑर्डर करना चाहते हो फ्राइज और तो मुझे वो फ्राइज नहीं करनी और मैं जब तक नहीं हो मैं बताऊंगा मेरे साथ। अच्छा तीन के लिए माइटी कर दो, उसमें दो होती है, तीन माइटी कर दो और एक जो चिकन का जो छोटा होता है
Maybe we should be muted.
This is
Natasha. Natasha, thanks for opening up the discussion. I think we've come a long way, because I think one of the biggest challenges was access not to just reagents for testing, but the bottleneck for sampling has been huge. Because there's someone who's worked in, for example, for most of my research life, TB testing. In children, for example, nasopharyngeal swabs are thought to be what needs to be used, but it was such a big deal that when we started to look at rapid diagnostics for pediatric TB, the idea of even getting nasopharyngeal swabs was a problem. And then it became, for influenza testing, it was a very specialized swab. So there has been a revolution in terms of appropriate upper respiratory sampling, because now we understand, and we'd be able to apply it to other viruses as well, because if saliva and nasal swabs themselves, both nostril swabs and mid-turbinate swabs are acceptable samples, then that really opens up your bottlenecks. So I think that's one thing that people should apply. I believe that maybe not everywhere people are still sticking to nasopharyngeal swabs, and they should validate alternate, easier to use respiratory samples for testing, because it reduces both the PPE and the exposure requirement of the person sampling it, and it eases up obtaining the specimens from individuals. That's one thing. Secondly, RT-PCR testing was previously limited just to certain labs, and now many people have had to learn it and had to deal with a lot of the complexity of testing that was alien to them. So it's been hugely challenging, but moving forward, I think that hopefully there'll be benefits left over. COVID will end, and we will end up with good molecular training, or at least a higher baseline than before. That is how I would look at it optimistically.
So, Natasha and Zara, I wanted to say something. I think the important thing is to look forward. What happens, happened, and where we are going. I think my biggest concern for Pakistan is that when weather will get cold and flu and other respiratory illnesses will come forward also, like every year. And then the distinguishing between COVID and other cold or respiratory tract viruses. I think we need to work on a test which uh, which which identifies different type of viruses like biofire instruments or some other virus, at least flu A and B and COVID. And I think that is to distinguish between these threes. Number three is that is like before vaccine is there. And once vaccine is there, I also believe that this will be like another flu, which is you just have to take vaccination. Some people will be immunized, and some, due to their own inherent and genetic conditions, will not be immunized, will not be properly immunized, and they will still get the disease. So and the type of testing. I think the basic difference between US and Pakistan is that who is directing the policies and procedures for the testing. I think for US, if any wants to, if government says that you have to go get tested, that means you will go get tested, irrespective if you have if you can pay for it or not pay for it. In Pakistan, I think it's sporadic, if not less. And certain areas where you can get free testing, but majority of testing is pay for service, means you have to pay to get the test done and get the results done. And it's your initiative, not, it may be a recommendation, but it's your initiative to get tests done. So prevalence really doesn't matter here. Means, if you are, if out of 100 people, 20 people can afford to get testing done and get the results done, that's very selected population. And so for prevalence testing, government has to come forward and mandate.
I think the government, Dr. Naeem, I think the government did actually ramp up its free testing by actually trying to get the resources to laboratories by providing them kits and extraction kits and amplification kits. And I think they did try and then but again, this was province based. You're absolutely right. So Sindh and Punjab, where they did have the network of laboratories there, they were able to ramp this up. But obviously in other provinces like KPK and Balochistan, they haven't been able to do that as effectively. So therefore, if you look at the number of case detections, they may be there, but you were absolutely right. We have no idea because of the limited amount of testing that was being done there. So I think, again, Zara has also suggested this, that and also mentioned it in her talk, that really we don't know what these numbers mean, and it's very difficult to interpret too much. But nonetheless, we do have numbers. We do have test positivity rates from different provinces, from different cities, and that is some kind of at least guide to what's going on. And I think that this is, again, ties in very, very importantly to what you're saying, which is that how do we move forward from this? Because we've equipped, and a lot of these places have been given the facilities and the training to do molecular testing. And I'd like to see this continue. You're absolutely right. It doesn't stop here, because we're looking to see and to keep monitoring and surveillance. I mean, we're sort of now really should be planning for
Yes.
disease surveillance.
Right. So, how to deal with this in flu season? I think that's the question government and the institute need to look into this. We don't want to treat everyone with respiratory illness with expensive medication and may sometimes life-threatening medications. You only need it for people who are positive. So anyway, that's a very good discussion. I learned a lot, and thank you so much. I'm going to log off now, and thanks for having me and for Pakistan Society of Immunology and EMPP, which is which I can't wait to have this lift open and come visit Pakistan soon, inshallah.
Inshallah. Thank you, Dr. Rizwan, and thank you, everybody. See you, inshallah, on 17th and 24th again. Bye-bye.